evidence-based antibiotic protocols for the treatment of prosthetic joint infections. I'm an infectious disease consultant. I do analyze the reports that are produced by Dr. Bhavin Kapadia and do a clinical judgment and provide results on prosthetic joint infections. So if you look at this old clinical infectious disease journal, it quotes PJIs as a bane of orthopedists. It's a headache for an orthopedist. It's a challenge for an ID specialist and a catastrophe for the patients. This lady from Surat had come with a 2-month history of pain and swelling post TKR. She had a sinus with minimal pus discharge. So does she have a PJI? If so, then what are the diagnostic strategies and what are the rational evidence-based antibiotic protocols for her? I think one of the speakers had quoted this particular definition that ranges right from 2013 IDSA definition of prosthetic joint infection to this 2018 International Consensus Meeting ICM definition, wherein they've taken into consideration the 2 positive cultures of the same organism or a sinus tract. In addition to that, they've taken into consideration the serum CRP levels, elevated ESRs, synovial fluid pleocytosis with predominant polymorphs, and that included positive alpha defensins also into that. So if you look at the definition of PJIs also has traversed right from 2013 IDSA to ICM definition currently. So if you look at the pathogenesis of a prosthetic joint infection, the essence is a biofilm formation. And this biofilm formation essentially involves intercommunications between the bacteria. Consequently, they enter into a dormant state, and whatever the antibiotics that you give, those essentially don't penetrate this particular biofilms, and therefore there are huge amount of relapses that you see. The clinical implications of this is perceived as the amount of relapses and the multiple antibiotic doses that are required. Right. So if you look at the diagnosis, I think Dr. Kapadia has stressed a lot on that. Elevated CRP levels forms the initial screening line. But for low virulence organisms, CRP might be normal also. Right. So for synovial markers, increase in synovial fluid WBCs and polymorphs. Alpha defensin has recently come up. The sensitivity is almost the same for other synovial markers now, right? And remember one thing, whenever you are taking the culture samples, it is always prudent to take 3 to 5 intraoperative tissue culture samples. More recently, I think PCR has come up, and next-gen sequences, as Dr. Kapadia mentioned, is also coming up now. Okay, so this is the protocol for the diagnosis of a prosthetic joint infection. You have a clinical suspicion of the PJI. Your CRP is elevated, right? You've done a arthrocentesis. There is increase in the synovial WBC count. Remember, for a PJI, the cutoff level as compared to that of septic arthritis is pretty low. So even if you have 3,000 or 2,700 as per any GM article, right, you can consider for a prosthetic joint infection. Right, synovial fluid culture is sent, which comes as positive. Ideally, you require 2 to be positive, right? And then you can prepare your subsequent plan, right? So this is what about the Indian data? This is a very important study published by Sebastian et al. It included some 106 patients, right? The incidence of PGI was 1.1%. And the most striking thing is that the gram-negative infections are on a rise in India as a whole. So earlier, I think when I used to speak, before some 5 to 7 years, MRSA, MSSAs were the predominant ones. But as per this particular study and as per the experience currently, GNBs are also predominating. So expect your E. coli, Klebsiellas, Acinetobacters also to predominate into that. Okay. So this is the profile that I was talking about, right? Your escape organisms. You expect Enterobacter cloacae. That is also one of the emerging ones that is coming up, one of the most dangerous bacterium you can encounter, right? Okay, so technically speaking, orthopedician always tends to classify it as an acute PJI and a chronic PJI. By and large, DARE, when it is applied, has a success rate of around 60 to 70% as per the studies. Nevertheless, if you have very high persistent CRP levels of bad organisms that you are dealing with, say for example, Klebsiella, MDR, which is MDR, or Acinetobacter, or a resistant MRSA, then the chance of success of DARE also is diminished. For chronic PJIs, ideally a two-stage procedure is preferred. So when you look at principles of PJI management, the first is a good thorough debridement with a competent surgeon that reduces the bacterial load, allows the antibiotic to penetrate well into the tissues. The second is the selection of antimicrobials, which is very important. An antimicrobial which has got very good biofilm penetration, right, and the duration of antibiotic therapy, which tends to be prolonged. So in addition to that, microbial tolerance and developing during maturation of the biofilm is also very important. Biofilm active therapy in the case of staph consists of rifampicin. Do not use rifampicin alone. Always combine it with another agent, say for example, a fluoroquinolone or minocycline or any other agent. Rifampicin can, if used alone, can develop rapid resistance, right? Use it doses 40 mg BD, monitor SGPT whenever you are using rifampicin, right? Nowadays for rifampicin, for streptococci and Cutibacterium. Cutibacterium is your good old Propionibacterium acne. Now it is known as Cutibacterium, by the way, right? So for shoulder surgeries especially, right? Okay, so in addition to that, FQs, fluoroquinolones show good in vitro activity against biofilm produced by certain gram-negative organisms. Right, so this is a very good slide that compares the IV antibiotics with the compared to the oral antibiotic therapies. IV antibiotics generally has the advantage of usage of high drug dosages, very good optimization of PK/PD, your pharmacokinetic and pharmacodynamic data, and 100% bioavailability, which is lacking in oral antibiotic therapy. Nevertheless, you require continuous IV access for IV antibiotics, which is not required in oral antibiotic therapies, right? If you see this, Zeller et al. Has given a very good chart. With initial IV course, you have a susceptible organism, say for example, MSSA, and you've got a complete wound closure, no massive bone graft, good antibiotic tolerance, treatment understood and accepted by the patient. You give antibiotics for 2 weeks IV therapy, right, and switch it to oral treatment regimen. Whereas if you are not having any of this, if you have a very bad MRSA or a bad Klebsiella that you are dealing with, you might require prolonged IV treatment. Okay, so good stress on this particular slide. Antibiotic therapy, I'll take just 1 or 2 minutes more.
Okay.
Antibiotic therapy for prosthetic joint infections, targeted treatment. If you are dealing with MSSA, beta-lactam antibiotics are the treatment of choice. Methicillin, ask your microbiologist whether it is methicillin sensitive or methicillin resistant. If it is methicillin sensitive, use beta-lactams. Flucloxacillin is available. Cloxacillin is available in India as of now. So use beta-lactam antibiotics, don't use vancomycin, right? If you are dealing with MRSA, treatment of choice is vancomycin, daptomycin, or teicoplanin in those cases, right? Similarly, if you are facing streptococcus, penicillin group is the treatment of choice. For gram-negative ones, E. coli, Klebsiella, Pseudomonas are now turning highly resistant. So definitely go for culture sensitivity and use as per sensitivity. In today's time, 70% of the isolates of gram-negatives are resistant to carbapenem group, that is meropenem group, right? So always take into consideration the MICs as provided by the microbiologist and move forwards in gram-negatives. Your DARE might fail in gram-negative infections, so be aware of that and counsel the patients accordingly. Okay, so now the phase is coming where prolonged antibiotics are being replaced with shorter antibiotic regimens. You have RCTs also now. This RCT particular was a non-inferiority trial that compared shorter antibiotic regimen, that is a 6 weeks regimen, compared to that of a 12 weeks regimen. And here it was non-inferior in this particular subgroup of patients. This is the NEJM article again, where some 410 patients, 410 patients, a pretty good sample size that was assessed, right? But nevertheless, non-inferiority was not shown, and therefore there is a controversy regarding reduction in the shorter duration of treatment versus the longer duration of treatment. Okay, so duration of antibiotic therapy, if you're facing a PJI, if you've done exchange arthroplasty, there is extensive bone grafting, extensive osteomyelitis, patient is immunosuppressed, right? If yes, then go for 12 weeks of antibiotic therapy minimum. But on the other hand, if that is not there, the patient is not having extensive bone grafting, patient is immunocompetent, there is no extensive osteomyelitis, you can go with 6 weeks of antibiotic therapy. Remember, for DARE, you might require 12 weeks of antibiotic therapy and more if your CRP is not settling and the patient is not settling on that particular parameters. Last slide, this is a very important slide, local antimicrobials in bone cement. Very often I get questions from the operation theater itself, right? So please note that if you're facing a standard situation, susceptible pathogens, say for example, MSSA while you are in OT, in spacer cement, you would require gentamicin 1 gram and clindamycin 1 gram. Optionally, 2 gram vancomycin also can be used. Special situations, MRSA is there or Enterococcus species is there, use 0.5 gram of genta with 2 grams of vancomycin. Right? So that is how you formulate the cementing concentrations of antibiotics. Of late, the gram-negative infections are also increasing, and therefore, combine gentamicin with either colistin. Colistin use 2 MIU, 2 million units with gentamicin, or if colistin is not available, use 3 gram meropenem in combination with gentamicin. Keep a watch over renal function. So that is how we formulate your cementing concentration antibiotics, which is, I think, very helpful. Of late, the incidence of candida infections is also increasing. Whenever you are doing a 2-stage revisions for that, the amount of concentration of antifungal required is also specified now. Use liposomal amphotericin B, 0.4 gram, that is available now in majority of the hospital, liposomal amphotericin, or use voriconazole, 0.4 gram in your spacer cement. All right. So by and large, if you see the incidence of PJIs is increasing day by day as the TKRs and THRs are increasing. In the last several years, several studies are being done to reduce the duration of antibiotic therapy. How much it will be successful, I think that time will dictate. In addition to that, right, nowadays local antibiotics are also coming up. I've already specified for MSSA use beta-lactam antibiotics. For MRSA, use vancomycin, daptomycin, or this thing. Now, dalbavancin is also available in India. Remember that your culture and sensitivity still is the gold standard. Upcoming investigations are the biofire that is available. If you are facing a culture negative PJI, you can use 16S sequencing of the RNA. That is one of the last resort available. And thank you very much to the organizers and to the audience for patient listening. Thank you very much.
Thank you, sir.